As we start to talk about rescue and treatment, I want to tell you a story about a situation where you might be involved, where you're rescuing someone and where the information we've learned so far might have actually changed the outcome. This is in the early 90s when most people did not know much of what we're talking about in the last hour or so. And there were two couples had been to a bar and they were going home early in the, after midnight. And they were on two couples on two snowmobiles, and they drove home via a sewage lagoon. And as they were crossing the ice, they broke through the ice, and you had two couples in the water. One of the couples was able to get out, and they walked a certain distance till they were able to call for help. And it took about 15 to 20 minutes for the RCMP to arrive on scene. And back then, as many of you might have responded yesterday, basically they thought these people are in ice cold water. They don't have very long to live. And what they did is they just kind of got tunnel vision. And I want to thank the RCMP officer who was in charge of this. He's given me permission to tell this story. And this does not speak negative about them in any way, because back then people did not know this information. And so they just thought, as everybody did at the time, that these people are going to die of hypothermia very quickly. Well, the woman, in fact, had drowned, and they would have thought it was because of hypothermia, and now you all know that wearing a snowmobile suit, she drowned, but not because of hypothermia, maybe cold incapacitation. And so they just focused everything on rescuing this person as fast as they could with what they had with them, which was not very much. I mean, they were basically police cruisers, and while they were waiting for better equipped vehicles, one person walked out on the ice to see if they could get out there, broke through. They had to get him back. There was a boat laying on shore that they pushed out with them, and then the ice started to break, and they got in the boat, and the boat actually had holes in it, so it started to fill up with water. And basically, they were not able to do very much, and they spent all their time focusing on how do we get to the victim as quickly as we can, without thinking about other things. The survivor was actually in the middle of the ice opening. He was in about 8 feet of water, 6 to 8 feet of water, and he happened to be standing on his snowmobile. So he was able to stand about like this in the middle of this big hole. And 25 minutes into the event, this person just kind of collapsed and drowned right in front of them. Now, was that person significantly hypothermic? No. Why did the person kind of collapse? Probably cold incapacitation. And so I spoke to the officer in charge just a few years ago, and I said, okay, and I basically told him what we've learned about the 3 phases of cold water immersion. And I said, knowing that, what would you say to this approach? If you said to the victim, okay, listen, we can't come to get you right now. We're waiting for some more equipment to get out here, but you are not in big danger right now. You're going to be okay. What I want you to do is look at me and swim those 10 feet from where you are now to the edge of the ice and get your arms on the ice. And get that person to the ice, no matter what kind of coaxing or yelling or screaming you'd have to do. And once the person's got his arms on the ice, it doesn't take any effort to stay in that position. And now, if that person kind of slumped and became incapacitated, he wouldn't drown in the middle of that big opening. He would have been supported by the ice. And the officer at the time said, boy, I wish I had known that, because that absolutely would have changed how we would have handled that case. And this is where the rubber hits the road, or the paddle hits the water, right? We are learning things in this video that can help you maybe survive if you're a victim, but this is really what could affect you as rescuers. If you understand that your victim's not going to die in minutes because of hypothermia, that allows you to step back and look at some other options. Like, if they could have got him to get his arms on the ice, they were 20 minutes out of Regina. They could literally have driven to Regina to get something, because this person could have survived for another hour or two or more. He did have a snowmobile suit on. So this is very, very relevant information. So when you do get to a victim, we're going to deal with rescue and treatment. The first thing will be rescue, and then we'll treat them. So the first thing I think most of us know when we talk about rescue is safety. This is the one time when it's okay to be selfish and think about yourself, because it doesn't do anybody any good if you become another victim. And then you think of others, make sure that nobody else is going to become a victim, and then you can start taking care of the victim. And when we're talking about rescuer safety, you know, many of you will probably have protocols for this. Some of you might not. If you don't, you should. If you are ever going to go past the shoreline, either into water or onto ice, you should absolutely have flotation on. If it's cold water or you're on ice, it should be thermal protection. You should be wearing something like that so that if you break through the ice, you're bomb-proof. You're not going to be another victim. When you actually take the course on ice rescue, you put this on and you go play in the ice water. It's no big deal. The other thing is, if you happen to be in a boat or whatever, don't tip it. You don't want to fall in, and as we do some extractions in the next little while, those demonstrations, we will learn that, you know, if you do an extraction and pull someone out of the water the wrong way in the right kind of boat, you're going to actually tip the boat, and that will be at least embarrassing, if not a big problem in real life. And there are other things that you can think about as far as safety goes as well. Now that we got everybody safe, you can start to think about care of the victim. And there are two major words when it comes to care of the victim, and that is gentle and horizontal. Okay, you want to be as gentle as possible. We have talked about it before, but a cold heart is very susceptible to going into ventricular fibrillation. And if you just treat somebody roughly by dragging them across to get to a safe area or a smooth area or whatever, or roughly drag them over into a boat, you could put them into ventricular fibrillation right there. The other issue is you want to make sure that they stay as horizontal as possible. When you put someone who's cold, you put them upright, blood will tend to pool down into the legs, blood pressure will drop. The heart, which is cold, works harder to try and maintain blood pressure, and that might be just enough to put that heart into fibrillation. And so we've talked about that here. The other thing is you want to protect people from the environment. And remember, just getting them out of the cold, the environment is not necessarily just the cold air around. Protecting them from the environment is also the water you just took them out of. Remember, if you're just getting someone out of the water, you're doing them a big favor if you don't do another thing. You've decreased their heat loss from maybe 1,600 watts to 200 watts. But then you want to, of course, do what you can and package the patient. If you're right close to an ambulance, well, of course, you just want to get them on the stretcher, get them in the ambulance and move on. But in a situation where there might be some transport time or some waiting time, then you might want to package the patient. And the basic principles are dry them if you can. You want to insulate them, absolutely, and apply a vapor barrier, and we'll get into that in just a moment. So here's a situation. This was a course I was teaching for some U.S. Navy SEALs up in Kodiak, and we had a demonstration day, and it was actually pretty cool. The CEO said, "What do you need?" This is about -2-degree water. It's salt water. I said, "Well, I need a couple people to go in the water." So he said, "Okay, you and you go jump in the water." I love the military. It's great. Anyway, so we only had them in there for 15 minutes. 15 minutes in -2-degree water. Not a medical problem whatsoever. They were cold, but you know, we knew that they are not going to become even mildly hypothermic in 15 minutes. But we had taught these principles so that you can imagine now someone not thinking about this. Everything's an emergency, right? Especially when someone's cold, they're really agitated, they're shaking, they're yelling at you, "Help me, I'm freezing." You can imagine getting someone to shore here, and the first thing that might happen is dragging them across this boulder field to get them up the hill to this area here. Well, you know, they'd learned this, and so there are several people there. What they had gotten is a canvas. They made a stretcher. They were very gentle with them. They picked them up, and they took turns as they tried to get them up this hill. There was no big rush to do a whole bunch of treatment right down here, because the fact that he's here is already big treatment. You've decreased his heat loss by 1,400 watts. You're doing him a favor. So you have time. And here's the other thing that's really important. If you understand that it's going to take an hour or more to get really hypothermic, and understand those timelines, you can recognize that you can actually slow things down when you're treating a cold victim. It's not like if someone has a heart attack, that is a temporal emergency. I need to do something right now within the next 60 seconds or this person could die. If someone is choking, that's a temporal emergency. I've got to fix this right now. When you're dealing with a cold victim, it's taken a long time for them to get that cold, and things have slowed down in their body, their heart rate's down, their metabolism is down, and you know that it's possible if I treat them roughly, I can put them into ventricular fibrillation. So if it takes you a few minutes to organize yourself to be able to gently carry somebody somewhere, those extra few minutes are not going to make their condition any worse. They've been freezing for an hour in real life. This person was only 15 minutes, but an hour or more. So taking the extra time to be gentle and keeping the person horizontal will not make the situation worse. But not rushing and dragging them around keeps you from potentially putting them into ventricular fibrillation. So handle them gently, keep them flat, and then we put them in this cocoon here. And again, this is relevant only if you're going to be waiting for rescue for a while or waiting for the EMS people to arrive. You might be a part of an advanced team, but your backup is coming. So you have the insulation, which now you can speak to when you know the mechanisms of heat loss. What kind of heat loss will that insulative bag stop? What kind of heat loss? And also, sorry, there is also a thin sleeping pad underneath here. So you're stopping what kind of heat loss? Convection and conduction. Person's lying on cold ground. You've got sleeping bag, sleeping pad. They're conducting less heat away. Just anything you wrap them in will slow the movement of air across them. So you're decreasing convective heat loss. What's the plastic for? There's actually two reasons for the plastic.
It stops the evaporation?
Right. It stops evaporation. This person came out of here, they're going to be wet. Remember at the beginning we talked about normally evaporation is an issue when you're too hot, you sweat, but if your situation was that you were in a wet environment, you've got water, so you're going to be at risk of losing heat through evaporation. So wrapping them in plastic or a vapor barrier will definitely decrease that. The other thing that people really don't think about that you can use your piece of plastic or vapor barrier for is you can actually protect your insulation. Okay, so if your insulation is wet, then its ability to stop conductive heat loss is greatly diminished. So what you need to do, if you've ever seen a cocoon kind of thing like this, it's usually looking like this with the plastic on the outside. Well, this is only going to work if the person on the inside is dry. In this case, they did cut his clothing off, they blotted his skin dry, and then they put him in here. So what you need to do is think about where will the water be coming from. Some of our extractions that we're going to do and practicing is going to be we're taking people right out of the water and we're going to put them in a cocoon in the boat. Well, now where's the water coming from? Not the sky, it's coming from the person. In this case, where would you put the plastic? You would put the plastic inside the sleeping bag. Open the sleeping bag, plastic on top, put your victim in there, wrap in plastic, close the sleeping bag, and now, it doesn't matter where the plastic is, it'll stop evaporative heat loss, but now it's also protecting your sleeping bag from getting wet. Very important. Last point is fuel shivering if practical. If the person is mildly hypothermic and alert, you could give them, a drink of warm chocolate or any other drink that had lots of calories in it. So, I've given you some textbook things, right? Be gentle, be horizontal. And some of you may be sitting here thinking, yeah, well, that's easy to say standing here, but in real life, life gets difficult, and I understand that. The issue is, do you remember the principle, and then just when you get to real life, apply it as well as you can. And this is something that we are really going to try and work on over the next couple of days. And you should try to work on in any training that you do. Take the time, say, okay, we're going to slow down. How do we set this up properly, even ahead of time, to make the transport as little as possible? But during the actual activity itself, let's take an extra 20 seconds and make sure that we can be as gentle as possible. During the actual extraction, sometimes you just have to do what you have to do. Gentle and horizontal may mean nothing at that time. But soon thereafter, as soon as you get to a stable position, you can actually switch from what do I have to do now to what can I do to follow that principle. We've got the person out, and now we can start thinking about treatment. Some important issues, again, we've just gone over it. Is it an emergency or is it urgent? And I kind of define them different. Emergent means if I don't do something right now, I have a big problem. Urgent is this is a serious scenario, but I have some time. If I don't do anything, it will become deadly or very, very serious, but I do have some time to deal with it. Question of active warming pre-hospital. For many years there were questions about this, and there are many doctrines in the military and treatment protocols that said do not warm anybody outside of the hospital. It can be very dangerous. I'll tell you now, and we'll give you some data later. Unless you put somebody in a tank of warm water, which could be possible if you found somebody in a bush near a cabin somewhere, never, never, never put somebody in a tub of warm water. And other than that, any source of heat that you would have at your disposal is not going to be dangerous to the patient. We will be seeing some different types of heat sources that we can add later on, and that you can do without worrying about any safety issues. The victim, you don't want them to do any physical activity. If someone like the gal who you saw swim for 2.5 minutes, collapsed, looked like she was dying from her circumrescue collapse, we interviewed her for 5 minutes. She got up and walked away. No problem. We knew it was a 2.5 minute submersion. But if you get a patient who you don't know how long they've been there, or it's been 20 or 30 minutes, you no longer want them to be walking because they're upright. That's not horizontal. Blood pressure can drop, heart can work harder. So, and often when someone is mildly hypothermic, they're a little, they're a little agitated. You go, leave me alone, I'm okay, I can walk over there. No. You say, no, I'm here, we'll take care of you. We're trained professionals, we'll take care of you. Lie down and we'll get you to help. CPR, do you do CPR? Of course, if you know the heart's not working, you can do you should do CPR. The problem, as we will see in a moment, with a cold victim, a victim who could be without a heart rate because of the cold, is going to be a stiff piece of meat that's going to be very difficult to tell if they have a heart rate or not. And we will talk about that, and we'll end up with fluid replacement. So the main priorities are to arrest the fall in core temperature, to maintain cardiovascular stability, and to establish a steady, safe warming rate. Notice we're never going to talk about speed of rewarming. All I know is if I can stop the heart from getting colder, that's got to be good. And it's important early on because there's a phenomenon called the afterdrop, and this happens in everybody. If you put someone in the cold and you take them out, for a period of time, the core temperature will continue to decrease. And there are a number of mechanisms for that. But first of all, the amount is important. Your temperature can drop for as little as half a degree to as much as 4 degrees. That's a lot. If you're mildly hypothermic, 35 degrees, you drop a degree, you go down to 34, no big deal. You'll bounce back from that. But if you get someone who's 31 degrees and they could theoretically be walking slowly or whatever, and you let them continue to walk, or you lift them up and let them walk, and they drop their temperature 2 or 3 degrees, well, now you put them into severe hypothermia just by your own actions. And if the rough handling didn't put them into ventricular fibrillation, the big drop in temperature might put them into ventricular fibrillation. So we talk about, that's one of the reasons why we want to be gentle, keep them horizontal. One of there are several factors, again, that cause the temperature to continue to decrease. The one that we can control is this. Anything that increases blood flow to colder tissue is going to cool that blood. And when it comes back to the heart, it'll drop the temperature of the heart, right? So if someone's been in water, we know about the vasoconstrictive response. Less blood flow to the limbs. Their limbs are really, really cold. Now you take them out, walk them around, stand them up or whatever, blood flows down there. You've got that blood pressure problem, but you've also got blood going through freezing legs, coming back and cooling off the heart. That is something you can control. Do whatever you can to make sure you don't increase blood flow to the limbs. And keeping them horizontal will go a long way towards doing that. The issue, we talked about drying. Gentle, horizontal, and the next step was, if you can, get them dry. And one of the ways, of course, is to take their wet clothing off. And but we also talked about the fact that any kind of rough handling, and it doesn't have to be bouncing along somewhere, just moving them around could put them in the ventricular fibrillation. So the question is, how do I get the wet clothing off? Do we kind of take it off, or do we cut it off? Most of the ambulance riders have got the quick draw with the scissors. There's no big problem. This is how we might package a patient. Okay, we've got, if you have some kind of insulation, you want to put it on. This actually has a built-in vapor barrier on that. That lining is vapor barrier. We didn't take all his clothes off for this picture, but basically we wrap him up in that so he is dry. And we also have one source of heat, which will show you. This is a charcoal heater, very effective, produces 250 watts of heat for as long as 8 to 12 hours until the charcoal briquette burns out. And then all you do is replace the briquette and you have another 8 to 12 hours of 250 watts of heat. And all I can tell you is, if you were cold and you were in a good insulated sleeping bag, you'd be very happy after about half an hour to have 250 watts of heat in there. When we get to advanced care, like in an ambulance or EMS situation, now we can start putting fluids into them to help bring back their blood volume. But it's very, very important to recognize that you must warm the IV fluids before you put them in. If you just put room temperature IV fluids in, you put 1 or 2 liters of that into a hypothermic person, you can drop their core temperature by half a degree or a degree or even more, and you can move them to the next stage of hypothermia. They could be in moderate hypothermia, and you can put them into severe hypothermia, and now you've caused a real serious problem. Now we need to classify hypothermia. People want to know, what are the definitions, what are the classifications? We have pretty well over the last 10 years standardized how we talk about hypothermia, and we've all heard the mild, moderate, and severe, and everybody wants to have a temperature with that. So over here we'll have it. The mild hypothermia is 35 down to 32, moderate is 32 down to 28, and severe is below 28. Some of the things that happen during cooling in mild hypothermia, you'll have physical impairment, starting with you won't be able to move your fingers as well, then you won't be able to move your arms and legs as well, and you will start to get mental impairment. But the main thing that we think you can use, that is actually what was used by a group of medical experts to actually define these numbers, was thermoregulatory status. If the thermoregulatory system is still functional, you're mildly hypothermic. And by and large, as you go from 35 down to 32 degrees, you have more stimulus to shiver, and you will shiver more. Down at 32 degrees, you'd be shivering so much you bounce off the bed if you were lying down and you couldn't stand up because you're shivering so much. In the moderate range, below 32, everything's starting to get colder. The controlling system gets colder. The shivering muscles get colder. So you actually decrease the ability to shiver, and it'll wax and wane, and finally it'll stop. And the same thing will happen with your consciousness. And 28 is picked as the threshold for severe hypothermia because at about this temperature or below, your heart is at risk of going into ventricular fibrillation or cardiac arrest. So, not many people can make measurements, but you can certainly look at a patient. Of course, you get a history and figure out, is there other things going on here? Is there a head injury? Is there alcohol or drugs involved? But by and large, if you can recognize that the main problem with this patient is that they are cold, you can just use these right here. Consciousness and level of shivering. Fairly awake, might be really nasty, not happy to talk to, but shivering vigorously, mild hypothermia. Not shivering so much, but clearly cold and mentally not doing so well, moderate hypothermia. Unconscious will absolutely be severely hypothermic. And when we treat people, we could treat them basically lump in. We treat mild hypothermia one way, and moderate to severe, we treat them all the same way. And the last thing I want to show you on this picture is these black bands, which are significant thresholds as you go through this cooling process. The first one is in the normal range. It happens right away. You get a cold sensation and you start shivering. Again, that does not mean you're hypothermic. That means you're cold stress and you're actually trying to prevent hypothermia. So when you have that, that's telling you I am in some kind of situation I probably shouldn't be in. I need more clothing or I need to get out of here or whatever. The next one is at about 30 degrees where, as a nice textbook number, shivering stops and you lose consciousness. But that is not the cause of death. The cause of death is when your heart stops, and at about 25 degrees you can go into spontaneous ventricular fibrillation or cardiac arrest just because the heart is too cold to operate. But remember, there's this range in here where you can put someone into the heart is in a situation where it can fibrillate if you do the wrong thing with them. Make it work harder by standing them up. Invoke that reflex that will happen if you treat them roughly. So that's why 28 is that threshold. This is a first aid pre-hospital care algorithm for what do you do with a cold patient. You rescue, you examine. Are they responsive? If they're responsive, you ask, are they shivering? If they're shivering, well, what are they? They're mildly hypothermic. You can wrap them up in that little cocoon. They will warm themselves up spontaneously. If they're not shivering, well, you still want to wrap them up. Very important. It's more important that you wrap them up in this case. And again, insulate, vapor barrier. Again, you would only provide fuel if they're conscious and alert. If they're not shivering, you're probably not going to do that. If they're mildly hypothermic, adding heat is optional if they're shivering, because they will eventually warm themselves up. If they're not shivering, heat is preferable. And this really relates to if the time to arriving at hospital is half an hour or more. If you're a 10-minute drive to the hospital, wrap them up, get them in there, be gentle, and just get them to the hospital. But in many cases, the time to hospital might be more than half an hour. Now, if they're not responsive, and here comes the issue with the CPR, when do we start chest compressions? Not responsive, check for respiration. If they are breathing, then you assume they have cardiac output. You can move over here. But if they are not breathing, you cannot register any breathing sounds or motions. Now you go, okay, well, maybe there is no cardiac output. Now you have to figure it out. You would make that decision in seconds with a heart attack victim, but not with a hypothermic victim. Because remember, they're stiff. Their heart rate may only be 4. Their cardiac output may be very, very low because their metabolic requirements are less, and they're stiff. So feeling a pulse might be very, very difficult. You could feel for a pulse for 10 seconds and miss a pulse that if they have four heartbeats a minute, right? So what we say is, first of all, check for a pulse, look, listen, and feel for 60 seconds, not the usual 10 or 15 seconds for a normal heart attack victim. If you cannot determine that there is heart rate or ventilation, then we want you to do rescue breathing for 3 minutes. And the reason we do that, and of course it would be best if you had a mask, use that. The reason we want you to do that is that if the heart is operating, that will increase the oxygenation of the heart and might perk it up a bit, strengthen it so that it will beat faster and stronger. And after these 3 minutes, you do another check for a pulse. And now you've given the heart the best shot it can have to let you know it's working. You feel for another 60 seconds, and sometimes that works. The heart was working better because it was better ventilated. Now I feel the pulse. Okay, do not do chest compressions. Because if I make a mistake and do chest compressions on a heart that is cold but beating, I'm probably going to put them in a ventricular fibrillation. If after that second check you can't feel any, you can't determine that there's any activity, then you're pretty safe in assuming, okay, there is no activity, we're going to start chest compressions. And then you would go with the protocol that whatever your jurisdiction dictates. Okay, and of course you want to add heat if you can, and in all cases get to a hospital. Just that when you're thinking about chest compressions, you want to do your best to determine that that heart is not working. And again, that's 5 minutes, right? 1 minute check, 3 minutes ventilation, 1 minute check. We can't wait 5 minutes to start chest compressions. Well, in a severely hypothermic person, you can, because their requirements for oxygen are much, much less, and the downside of waiting 5 minutes is pretty minimal compared to the downside of doing a chest compression when they had a heart that was working, because then they're dead for sure. So far we have dealt with cold water immersion where the victim's airway is open, they are breathing, and the main health threat is eventual hypothermia, when after 1 or more hours the heart will ultimately stop because of its low temperature, likely below 28 to 25 degrees Celsius. Cold water drowning is another condition which is more time sensitive. In this case, the victim no longer has a source of oxygen and the fatal event is brain death. A person can survive submersion longer in cold water because the brain cools, and a cold brain can survive without oxygen longer than at normal temperature. If a cold water drowning victim has been submerged for less than an hour, aggressive treatment is required. In this case, a single circulation check should be conducted for 60 seconds. If no cardiac activity is detected, CPR should be started immediately with priority given to reoxygenation over body rewarming. So I just leave you with that. There we go. That's how to rescue and how to treat people. Any questions about this?
You'd mentioned earlier that you shouldn't immerse the victim in warm water. Why is that?
Well, if you put somebody in warm water, the heat and the intense heating of that warm water can cause vasodilation. You know, anything else we do to somebody, when you're really, really cold, you're vasoconstricted. You add even a moderate amount of heat, you're going to stay vasoconstricted. But when you put someone in hot water, that massive stimulus will override your thermoregulatory mechanism, cause vasodilation, and now we have what? We have blood coursing out to the arms and legs, decreasing blood pressure, decreasing temperature, and all things that are bad for the heart. And we know of patients even in the ER back in the 50s and 60s when they used to do this. They would take a patient, put them in the water, and they go and died right there. I have a colleague who did that on his first 2 hypothermic patients, and then he said, well, I think I got to throw that textbook out and we have to look at something else here because that's not good. But from that experience, that got moved in, generalized to everything. People heard about those experiences. Oh, don't warm anybody ever because you'll cause massive vasodilation, and that's bad news for the patient. That's the only thing that you will have at your disposal, potentially, that could cause this problem. Anything else that we're going to talk about, heat packs, any of those kind of things, there's no way you're going to cause vasodilation.